It's old and proud to serve a sovereign motherland. Our flag shall be a symbol that truth and justice reign. In peace all battle honored, and this we count as gain. To hand unto our children a banner without stain. O God of all creation, grant this our one request. Help us to build a nation where no man is oppressed, and so with peace and plenty Nigeria may be blessed.
Indeed. Nigeria may be blessed. Okay, so that was a wonderful one. I don't know how many of us were able to sing that without looking at the screen, but then I know it's a work in progress. Very soon we'll be able to recite it by heart. Okay, so thank you for that. So next thing we have on our agenda now, and that is going to be a welcome address. We are going to be listening to a welcome address by our very able, very beautiful, capable president. I have the pleasure to welcome the president of Medical Women's Association of Nigeria, Delta State Branch, Dr. Olive Ogele. You're highly welcome, ma. Please, your welcome address, ma. Please, I don't know if I was heard.
Oh, yes, sorry. Okay. Can you hear me now?
Yes, we can hear you loud and clear. Good evening, ma.
Okay, good evening. Like I said, welcome to today's webinar. I would like to welcome everybody to today's webinar in commemoration of the Universal Health Coverage Day. This is being organized in collaboration with our MWAN AID-MNCNH, that's the Accelerating Innovative Management for Maternal, Newborn, Child Nutrition and Health Projects. It's a project that is being funded by the Bill and Melinda Gates Foundation. Also have other partners, Pathfinder, ASAP, and CCSI, that's the Center for Communication and Social Impact. MWAN is an organization that is dedicated to advancing healthcare, particularly for women and children. And the focus of this MNCNH project is to reduce maternal and maternal mortality rate. Unfortunately, Nigeria still has poor maternal indices, accounting for over a quarter of the global maternal deaths. And these maternal deaths in Nigeria are largely preventable, chief cause being postpartum hemorrhage. And these deaths have been followed by unlimited access to quality antenatal care. Now, universal health coverage should be a topic that resonates deeply amongst us, because healthcare, as we know, is a fundamental human right, and it must be upheld by all of us. And the theme of this year's Universal Healthcare Coverage Day is healthcare, it's on government. This theme, looking at it, highlights the critical role government has to play as the architect of our healthcare system in ensuring that they build a healthcare system that is not only sustainable, but a healthcare system that also addresses the needs of its population. And the theme also calls us to hold government accountable to ensuring that quality maternal health care is being provided in such a way that it helps to reduce these poor maternal indices. We have gathered together a crop of speakers that are very seasoned, experienced in their various fields of study, and we look forward to what they have for us. It promises to be an interesting, enlightening evening. And at the end, it's my hope that we'll consider this time well spent. So happy listening. Thank you very much.
Thank you very much, Ma, for that wonderful opening remarks. And indeed, like she has stated, we cannot overemphasize the importance of providing quality maternal health care. And with the way health is, we know that a lot of people, spend out of pocket, and universal health coverage is one way we can make sure that we reduce, improve the indices of maternal care. And so, thank you very much, Ma, for that welcome address. So if we look at our agenda, we'll see that we are going to be meeting our speakers. And like she said, we have seasoned speakers that are experts in their various fields, and they are going to be discussing a lot about maternal health and PPH, that's postpartum hemorrhage. And I know that at the end of this webinar, we would have learned so much. So we'll start by meeting our first speaker here, and we have the pleasure to read out a brief citation of dietitian Chrysanthus C. Odo. So he's a registered dietitian and a representative of Nutrition Society of Nigeria Delta State chapter. And so he has more than 15 years of experience in clinical and public health nutrition. He's a researcher and counselor of the Societies on Nutrition and Health via several media fora with keen interest in transforming health and mitigating the cause of diet-related diseases through nutrition mainstreaming activities. He holds a master's degree in clinical and public health nutrition from the reputable University of Nigeria, Nsukka. Currently, he works with the Federal Medical Center, Asaba, as a chief dietitian. He's also a member of different professional bodies like the Nutrition Society of Nigeria, both the National and Delta State chapter, and the Dietitians Association of Nigeria, respectively. As the secretary of the Nutrition Society of Nigeria, Delta State chapter, he represents the association in civil society scaling up nutrition in Nigeria, that's CSON, Delta State chapter, and Delta State Multi-Sectoral Technical Committee on the International Board of Marketing of Breast Milk Substitutes, that's BMS, being set up by NAFDAC. He has attended and also facilitated several capacity building trainings and workshops on maternal, infant, and young child nutrition, healing hunger, and various nutrition-sensitive agricultural interventions in the past. He is happily married with children. So this is one of the speakers that we're going to be listening to today. We know that he's well prepared for the topic you'll be handling today. So I also have the pleasure to also introduce us to one of our other speakers, a lovely doctor, Dr. Wayemi Ann Francis. She's the Reproductive Health Program Manager, Delta State Ministry of Health. So she is the State Program Manager for Reproductive and the Ministry of Health, Delta State. She has an MBBS and a Master's in Public Health, Reproductive from the University of Benin and Center for Excellence in Reproductive Health Innovation. She has a PhD in view of in reproductive and is from the University of Port Harcourt. She has over 8 years experience in public health space, working with governments at subnational level in various capacities. Currently, she's focused on improving the quality of her leadership skills, which has led her to take up courses and fellowships in leadership in several public health schools. She's an ardent believer in public health rights and overall women's health, and always ready to collaborate and find innovative ways to implement policies that reduce maternal and child mortalities. So that's our second speaker. And I have the pleasure to also introduce us to Dr. Jumbo Sunday Emmanuel. He's from Anyocha North in Delta State. He has had his several education right from primary, secondary, had his MBBS in Nnamdi Azikiwe University in Oka. He is a fellow of the National Postgraduate Medical College, and he also has an MSc in Reproductive Health from the University of Benin. He's also a fellow of the West African College of Surgeons, and he has membership from several bodies, which include Nigerian Medical Association, Society of Obstetrics and Gynecologists of Nigeria, and also from the National Institute of Management. He's also a national facilitator, training of trainers of PPH Prevention and Treatment, Federal Ministry of Health. He is the current head of Department of Obstetrics and Gynecology of Department in FMC Asaba. He has had over 22 publications in local and international reputable journals. He is married and blessed with children. As our third speaker, Dr. Jumbo. And we have our fourth speaker, Dr. Yinkore Paul. He is the Executive Director, Delta State Primary Healthcare Development Agency. He was born in the 1960s. He's an open-minded and a dependable son. He attended several schools and he moved to the prestigious, I must say, prestigious University of Calabar. He was awarded a combined bachelor's degree in medicine and surgery. He has built himself up over the years, acquiring a master's degree in health planning and management from the University of Benin, to certification in long and short-term courses in numerous spheres of life, including medical, administrative, socioeconomic, just to mention a few. Knowledge is power, and he enjoys exploring it, being open to listening and learning whatever, wherever, whenever, and whosoever, from whatsoever and whosoever provides the opportunity. Life is a continuum, and its dynamics must be understood for our adaptation, survival. The next, yes, so he is now dressed as a Nigeria registered medical practitioner, currently engaged by the Delta State Civil Service, and he's the incumbent executive director of the Delta State Primary Healthcare Development Agency. He's a seasoned civil servant that holds sway in medical practice, both public and primary healthcare, program planning, and execution. He imbibes teamwork and takes everyone to heart and cherishes positive contributions from team members for success. Yes, his contributions have won Delta State the status of a Guinea worm-free state for 24 years running, a polio-free state for over 14 years running, and there is more to come. Dr. Yinkore Paul is married to Yinkore Joan, and his woven family are Catholics and currently parishioners of St. Patrick's Catholic Church, West End, Asaba. He's a true son of the soil and a child of God. So these are our wonderful speakers that we're going to be listening to today. And I must say that we are in for a wonderful ride, if I must say. Our speakers are prepared and ready to deliver justice to their various topics. So from our agenda, we'll be going straight to listen to our first speaker. And I believe our first speaker, Dr. Yinkore, is on the call. We'll be listening to our first speaker, Dr. Yinkore. I don't know if he's on the Okay, so while I wait for confirmation, Dr. Yinkore is going to be talking to us on the role of primary healthcare in preventing in postpartum hemorrhage in Delta State. So while we wait for his confirmation, I think I would like us to go to the second speaker. Speaker will be hello, please. Okay, thank you. Be muted. So we'll be taking our second speaker while we would get to confirm if when Dr. Yinkore gets on the call, he will take his presentation. So I have the pleasure to introduce Dr. Wayemi Francis. She is the Reproductive Health Coordinator, Delta State Ministry of Health. She's one that I admire a lot. I don't think I've told her this before, but I admire her a lot. She's somebody that has a lot of successes under her belt. And she's someone I want to be like when I grow up, actually. So I have the pleasure to introduce to us Dr. Wayemi Francis, Reproductive Health Coordinator, and she'll be speaking to us on research and innovation for PPH prevention and management, lessons from Delta State, and implications for universal health coverage. You're welcome, Dr. Wayemi. You have 15 minutes, please.
Good evening. Good evening, everyone.
So
I don't know if you can hear me.
Yes, we can hear you loud and clear. Welcome.
All right, thank you. I want to acknowledge my senior colleagues here present and other colleagues. Permit me to align with already established protocol. I will be speaking on the research and innovation for postpartum hemorrhage, prevention and management, the lessons that we've gathered from Delta State Ministry of Health and then implications for universal health coverage. Let me quickly say that a few of the slides here are not mine. They have been put together by collaborative work from some of the partners that we've had in the Ministry of Health, and then some of them are mine. So I will be making this presentation under the following outline. I will give a brief introduction and overview, a definition of PPH and causes, prevalence of postpartum hemorrhage, key lessons from research and innovation, what the challenges have been, what the recommendations are, and then I will attempt to give a conclusion, and hopefully we can have a robust discussion following it. Now, I had assumed I would be the last speaker, so a lot of the clinical definitions are not here. But for a lot of us, we already know that postpartum hemorrhage is an obstetric emergency, can be defined as blood loss of more than 500 mils in 24 hours. And 1,000 if it is cesarean section. That is from a normal vaginal delivery. Postpartum hemorrhage remains the leading cause of maternal mortality globally, particularly in low-resource settings like Nigeria. Of course, being a obstetric emergency, it only goes to show that it is one of the killers of mothers in low-resource settings and in the world generally. In Delta State, efforts to address PPH have evolved through research-driven initiatives and innovative interventions, a lot of which Delta State Ministry of Health has feed into just because of the magnitude of mortalities that come from postpartum hemorrhage. Hopefully, we'll be speaking to some of these innovations that we've seen, and together we will discuss and agree that these lessons offer valuable insights, not just to strengthen universal health coverage, but also to strengthen the systems that we have in Delta State and in Nigeria as a whole. Next slide. So like I said before, maternal mortality is a public health problem. It's a very dangerous one, recorded in low and middle income countries, as well as other developed countries, but it is very significant in our countries and is one of the strongest indicators of a country's standard of living and maternal care. Every year, an estimated 14 million cases of PPH are recorded, 17,000 related maternal deaths globally. This implies that for every 4 minutes, one woman dies. And like the previous speaker said, it accounts for about 13.4 maternal deaths in high-income countries. Next slide. However, in Asia and Africa, the data is much more severe. We have 30.8 in Asia and 33.9 maternal deaths respectively, 33.9 in Africa. And one third, some will say more than one third of hospital admissions, PPH accounts for those hospital admissions due to complications of obstetric hemorrhage, and 42% of maternal deaths arise from these complications. Now, these statistics or data sets can vary from facility to facility. And so I'm just giving a broad overview of some of the statistics that we've been able to gather in the Ministry of Health. And so we know that a lot of the maternal deaths that take place can be prevented through the implementation of evidence-based strategies as articulated in the National Safe Motherhood Strategy and Guidelines towards the attainment of the Sustainable Development Goal Target 3 on maternal and newborn health, morbidity, and mortalities. And we'll be looking at those strategic plans today, and hopefully look at how far Delta State has been able to implement those strategies across all levels of care in Delta State. Now, this slide was, the data on this slide was put together, like I said, by a couple of partners and the ministry that worked together over a period of 6 months. And some of the data was gotten from DHIS2 and then NDHS 2018. This was done before the release of NDHS 2023. Like I said before, Nigeria has one of the highest burdens of maternal death worldwide, with postpartum hemorrhage being a leading cause. In Delta State, PPH data varies across facilities. In some facilities, it is the third leading cause. Some facilities, first leading cause, with hypertensive pregnancy and hypertension being the first cause, and then PPH a close second. We have about 900 maternal deaths in Delta State as recorded by the DHIS2, and 26% of those maternal deaths are said to be from postpartum hemorrhage. This is due to a lot of factors, challenges with postpartum hemorrhage prevention, detection, and treatment, the inability for healthcare workers to quickly identify PPH. It is said that only about 50% of PPH cases are diagnosed on time, and those referrals taken to facilities where they can be handled. And this delay of interventions worsen maternal outcomes at least by 26%. Some literature will tell you even up.
You're muted, ma'am.
Sorry, it's like your audio is a bit poor. Please check it's like you're muted.
Okay, sorry about that. So Delta State is in the South has one of the highest mortality rates that was recorded in the NDHS 2018. And this has been a source of concern for us because it has affected our mortality rates, and we have a lot of healthcare workers that are not properly trained, and a lot of poor referral procedures, and we are hoping that with a lot of the innovations and the research that has been done, all of the information that we've gathered from this research and innovations can be used to make a lot of policy changes that will positively affect the maternal health outcomes going forward in the future. Next slide, please. Okay, this is just an overview of what the drivers of postpartum hemorrhage are. I'm sure Dr. Jumbo is going to speak to all of this. We have basically the 40s, uterine atony, trauma, tissue, thrombin, and measures that are on ground to address these drivers. So I'll not speak too much to this. I'll allow the clinician speak to this. So next slide. So like I mentioned before, a lot of research have been done with regards to how to combat postpartum hemorrhage in the country, even outside the country. Few of which are significant, and I would just like to highlight briefly these three research that have been done. The first one is a research by Widner and Marina et al., which was done in 2017, and the research was on heat-stable capetocin. It spoke to the research title is Heat-Stable Capetocin versus Oxytocin in the prevention of hemorrhage after vaginal birth. And this research was published in the New England Journal of Medicine in 2018. This was a randomized clinical trial, which was done to compare the efficacy of heat-stable capetocin to oxytocin for PPH prevention. The objective of this research was to compare the non-inferiority of heat-stable capetocin to oxytocin for PPH prevention after vaginal birth. We all know that oxytocin is the gold standard uterotonic for PPH prevention, and we also know that it requires cold chain storage, which is widely unavailable in settings in Nigeria due to unreliability of electricity and poor refrigeration infrastructure. Now, I think this research was of particular concern to us, and I don't know if, I'm sure Dr. Jumbo was also part, or Sogon was part of this research, because it spoke to the gap that we had with regards to cold chain storage of oxytocin. The research was done in 10 countries, including Nigeria, across 23 sites, and about 29,000 women were reached. The results of this study showed that heat-stable capetocin was non-inferior to oxytocin for the prevention of blood loss of at least 500 mils, or the use of additional uterotonic agent. Now, if you look closely, you see that the pie chart compared the efficacy of oxytocin with heat-stable capetocin, and there was not much, or there was no significant difference. So the recommendation following this study spoke to the fact that capetocin, which is a heat-stable formulation, can be used as a new option for preventing PPH in settings where the quality of oxytocin cannot be guaranteed. And for a long time, we had in the facilities in Delta State, we had a lot of issues with the efficacy of oxytocin, just because it gets denatured in heat and the efficacy becomes compromised. And so this was one of the studies which was very, very essential to a lot of the decisions we made going forward in the reproductive health unit in the Ministry of Health. We know that they had a lot of brands that were, very expensive and only used for high-risk patients. But eventually, two partners, SMF and LifeBank, came together and brought in another brand, Cabetocin Ferrin, which was introduced into 8 states, including Delta State, and a study conducted to see how well clients, healthcare workers were able to use it, and if there was any considerable difference between the outcomes, maternal health outcomes, and PPH, with regards to PPH in these women. And we saw a lot of improvements in this. The second trial was a woman's trial, which demonstrated robust evidence at the effectiveness of tranexamic acid as a first-line drug in treating PPH. Again, this was another innovative research done, because it was a randomized double-blind control trial that compared, provided evidence on the efficacy of tranexamic acid for PPH. It was done in 21 countries, including Africa and Asia, Nigeria included. 193 hospitals were engaged and 20,000 women reached. And then the results showed that early treatment within 3 hours of tranexamic acid, alongside a uterotonic reduced PPH death by 30%, a whooping 30%. And all of these gave birth to the emotive bundle trial, which is the next slide. We can just go to the next slide. And the emotive trial, I think one of the most innovative and very apt, of our time, spoke to how effectively we can use this PPH bundle as a first response medicine and intervention, not just to detect, not just to prevent, but also to manage PPH. And so this bundle spoke to, combining preventive medical and supportive interventions into one single package, to reduce the treatment time and then to increase survival rates of clients or patients. And it was also designed for the ease of implementation in settings that, had little resources, and, there were constraints and gaps, areas that were not easy to reach. And it was, I believe, the beginning of great things to come, because it enhanced, the standard of care, and then there was a lot of improvement in maternal outcomes. So the recommendation, just to say that the results of this emotive bundle showed that there was a 60% reduction in maternal death, in blood loss, and in the need for laparotomies in clinical settings. And the recommendation, of course, following this research, was to use the use of this clinical bundle as a first response treatment for PPH. And we all know that, there was the pre-motive and then the emotive. And then the pre-motive aspect of it was the use of the calibrated drips to objectively ascertain how much loss of blood a woman had. Next slide. Okay, this is just showing a little bit of what I said about the prevention aspect of the emotive bundle, which is the introduction of the use of heat-stable carbetocin, oxytocin, or misoprostol. And then the E aspect of it was early detection. And then the emotive aspect of it was the treatment of postpartum hemorrhage. The whole bundle was advocated to be used all at once to considerably reduce maternal deaths following postpartum hemorrhage. Next slide. So what are the key lessons that we've learned from all of this research and innovations that have come out of the brilliance of a lot of minds in the reproductive health space? Once we have evidence-based practices that have been shown to considerably improve maternal health outcomes, we are always ready to adopt those practices and utilize them, domesticate them as soon as possible, and begin to ensure that those guidelines are cascaded down to the facilities, and healthcare workers are trained to use them. So we have that. Just to say, implemented key recommendations, of all of which I've just mentioned, from research on PPH, prevention, including the routine administration of uterotonics during the 3rd stage of labor, introduction of carbetocin for community level use where oxytocin storage is a challenge, training healthcare workers on active management of third stage of labor, and these contributions have contributed in reduction in maternal mortality rates in health facilities. The emotive bundle is one of which I just spoke about. So the integration of innovative tools and technologies for us in Delta State included the introduction of calibrated drips. We have had facilities begin to show interest, and only just recently, Smile for Mothers and the Solina Group, with Dr. Jumbo here as a trainer of trainers, have trained 25 obstetrician and gynecologists, along with some senior medical doctors, on the use of calibrated drips and emergency obstetric care, introducing the emotive bundle into the guidelines for PPH prevention and management. And so this innovation is something that we in the Ministry of Health have keyed into, and we have already, written for the purchase of calibrated drips, and we are hopefully going to roll it out within the first quarter of next year, so that we can use these drips to objectively ascertain how much women in labor are losing blood, especially in hard-to-reach areas, in the communities where it is difficult for us to have experienced doctors on ground during deliveries. We also have the innovation of the non-pneumatic and shock garment. Again, this is used to refer patients. It is used to prevent women from, going into hemodynamic shock, and during the process of referral, and then to reduce the amount of blood loss before they get to the secondary facilities or tertiary facilities, where help is a more definitive action can be taken to save the patient's life. We also have the innovative use of point-of-care hemoglobin testing, which we just also introduced to our primary healthcare centers, where a woman comes in the third trimester or during labor, and the healthcare worker is expected to check her blood level just to know the level of if there's anemia or not, and this can inform some kind of decisions that she can take just before the woman goes, hopefully not have PPH, but though the level of blood will give her an idea of what she can do just before she needs to refer the woman. And then, of course, the use of the emotive bundle. Next slide. Right. Okay, so again, a lot of policy decisions, that we had spoke to the necessity to involve community-based interventions in all of our management and referral procedures. And one of, I think for us in the state is one of our biggest gaps would be that the fact that we have a high patient care for traditional birth attendants. So a lot of women patronize these traditional birth attendants, and so as a state or as a Ministry of Health, we are looking at collaborating with TBAs to educate them on early referrals and possibly the use of misoprostol. So this is work in progress and is still in the developmental stage, but it's something that we are considerably looking into as to see how this can help improve maternal health outcomes in Delta State. For MPCDSR is maternal perinatal child death surveillance response, and it is used not just as a learning tool, but it's an audit committee that notifies and reports, and then audits any maternal death all the way from the state level down to the community level. And this for us has been a tool that we can use to look at whatever gaps that they're having in the community level, and assess the kind of delays that come with referrals, and then make informed and actionable policy changes based on what we have learned. So we have something called the verbal autopsy that is done at the community level, and at the PHC level, verbal autopsies are done, with the reproductive health supervisors present, and they try to investigate any kind of mortalities, maternal mortalities that happen outside the facility in the communities, most especially with the TBAs, and send back reports to the state. And this also informs what kind of actions we can take to help us reduce or prevent similar occurrences from happening. Also, we spoke about capacity building and stakeholder engagement. Again, another important intervention or strategy that we have also gotten from these new guidelines. We have these new guidelines, we have this new emotive bundle, and we need to, the healthcare workers need to know about it. So it's important for ongoing trainings to continue on PPH management protocols. So we have had the first 25 TOT that has been done, and hopefully these doctors are going to cascade this training down up to the community level for other health workers, so that when they can also apply the emotive bundle in the treatment and then referral cases of PPH. Next slide. So universal coverage, I think, which is today is World Universal Health Coverage Day, I believe, and it basically speaks to the fact that every human being, deserves to have access to full coverage of quality healthcare when they need it, where they need it, without financial hardship. And I believe that all of these innovations and research only speaks to, helping us move closer to our goal of universal health coverage, allowing or enabling individuals to have access to healthcare, the full coverage of healthcare, from health promotion to diagnosis to prevention to treatment, without bias to who the person is or where the person comes from, is, I believe, what our goal is as healthcare workers and stakeholders in the healthcare space. So that being said, the implication for universal health coverage and all of the lessons that we have learned, is driving us to these goals, which are to have or to provide equitable access to essential maternal health services. Innovations such as start shifting and sharing, where we can train, allows us to train healthcare workers that are not just nurses or doctors, but we are talking about community health extension workers, junior community health extension workers, to be able to take deliveries, and to be able to learn about how to identify danger signs and quickly refer. Excuse me. And also to speak to the innovative heat-stable carbetocin, which has come into the country, and how quickly we can, as a state, include it in our guidelines for prevention, not just for prevention, but also management of postpartum
Sorry, so sorry
hemorrhage.
to interrupt you, Dr. Wayemi, but you just have a few minutes more, please.
Okay, so equitable access to essential maternal health system strengthening, also very essential. Next slide. Excuse me. So policy and advocacy, very important, because the findings from every research that we do underscores the importance of a policy commitment to maternal health. So states implementing strategies like the MPCDSR, community engagement, behavioral change, ensuring that whatever maternal health commodities we have get to the last facility or get to the last client, just ensuring that we have all of this in place will help improve our goal or increase our goals to whatever objectives we have to attaining universal health coverage. So I also mentioned community engagement, monitoring and evaluation, very important because systematic data collection is important. Again, like I mentioned before, we have so we need as a state have one unified data that speaks to Delta State. This is next slide. And that can help us with regards to informed decisions. What are our challenges? I mentioned a lot of innovations, that have come to stay, that as a state, we have we have domesticated and we are in the process of rolling out. One of which is the calibrated drapes. Another one is the anti-shock garment. Accessibility to uterotonics, especially heat-stable carbetocin in the communities, in the primary healthcare centers, because there is a challenge of the pricing, being able to imbibe or include all of this in our insurance health scheme to make it easier for the ordinary or man or people that don't have much money to access it. We also have sociocultural barriers to facility-based deliveries, a huge challenge for us because I mentioned TBAs, a lot of women going to TBAs as opposed to facility deliveries. And at this point, because we haven't trained a lot of healthcare workers, we hope that we'll be able to surpass this and increase our capacity with regards to just being able to address complications of delivery. Resistance to adopting new guidelines in some healthcare settings. I'm going to let the guys at the top speak to that. What are the recommendations? Strengthening of supply chain for essential PPH management tools like the e-motive bundle, making it accessible for facilities to, be able to use or get from the drug revolving fund if necessary, and have them fully stocked in the facilities. Expanding training for healthcare providers, increase community awareness, advocacy, and respectful maternal care, which is essential across board, and then monitor and evaluate the implementation of the national guidelines to identify gaps. So in conclusion, Delta State efforts demonstrate that research and innovation, including adoption of the emotive bundle and new guidelines, are critical for addressing PPH and achieving universal health coverage. Scaling up these lessons across Delta State and indeed Nigeria and similar contexts will require robust investments in health systems, strategic partnerships, and unwavering political commitment to maternal health. And by prioritizing evidence-based interventions and fostering innovation, the dream of universal access to quality maternal health care can be realized. Thank you very much.
Thank you very much, Dr. Webi. That was an awesome presentation, very well delivered. And thank you for, throwing a lot of lights, as people usually say, to what Delta State is doing in trying to see how we can reduce the indices. So when I saw how much has you have put in, you and your team and Delta State in terms of all the work and all the research that's been going through, I'm really proud, say yes, I'm from Delta, but then there are a lot of questions on the chat box, but we'll be taking that after the second presentation. But I also like to use the opportunity to welcome specially on a Zoom call our President-elect, Medical Women's Association of Nigeria, our National President-elect, Dr. Zainab is on the call. And so we'd like to specially welcome you, Ma. We say, no, Migwo, welcome to the call. We are happy to have you here. And every other person that has joined the call, we are happy to have you. So we just listened to Dr. Wayemi Francis. She is the Reproductive Health Coordinator for Delta State Ministry of Health. She just finished her presentation on research and innovation for PPH prevention and management, lessons from Delta State and implications for universal health coverage. And you can agree with me that she did justice to that topic. And we have some questions, but we'll take that after the next presentation. Thank you so much, Dr. Wayne. So I would like to invite our second speaker. He's somebody that we know so much because of all that he's doing in Delta State. So I have the singular honor to invite Dr. Yinkore Paul to take, he's going to be talking on the role of primary health care in preventing and managing postpartum hemorrhage in Delta State. Dr. Yinkore Paul, we are happy to have you on the call, sir. Please, you have 15 minutes, sir. Thank you.
Thank you, dear. I want to use this opportunity to appreciate the efforts of all our collaborators, especially the Medical Women Association of Nigeria, the accelerating improvement in the maternal newborn child health nutrition, the Belinda Bill Gates Foundation, and also other partners who are supporting this year's celebration of the universal health coverage. I want to use the opportunity to say the topic you are choosing and those of you who are collaborating is very apt, because up to now we understand that in the population, women and children are still the most vulnerable. When we talk about childbirth, we don't yes to the highest cause of maternal death. And we agree with everybody, and the global community agrees that every pregnancy should go to full term, and also that babies are also put to bed safely. Now, for me, my presentation is going to be short because my presentation is not going to be too far, not too different from what Dr. Wayemi has presented, but I will look at some key areas that will interest us as to what government has done and what is the position of primary health care in the country and also in the state. You can just quickly scroll down to slide. If you want, you said 15 minutes, so let me make it brief. Go to slide 4, 5, we'll go to 14, and we'll go to 15. All the others, I know Dr. Wayemi must have spoken about them. So can you take me to slide? Yeah. Slide 4, the issues are already highlighted that the causes of PPH are often summarized as follows. Take uterine, that is tony. When we talk about the tone of the uterus, say there is atony, it could be a problem. There is trauma due to birth injuries, and then tissue retention during childbirth, and also blood clotting deficiencies. So any of those could also be a problem. Next slide. Next slide. Next slide. Yeah, now the importance of primary health care and PPH could be summarized in the following areas: that the primary health care facilities are vital in addressing postpartum hemorrhage, while which is a leading cause of maternal mortality in Nigeria. And therefore, we cannot do it alone, since we understand that we have 3 levels of care. We have the primary, we have the secondary, we also have the tertiary. And also we understand that health is on the concurrent list, meaning that all levels of government should be involved. And beyond that, too, we also believe in what we call the public-private partnership. This calls for integration of programs. This calls for integration of programs. In other words, by integration, next slide. Next slide. All right. The slide, please. Hello.
The slide is up on my end, sir.
All right. So for the key functions of primary health care in preventing and managing PPH, we can see them the way they are spelled out. We need to engage skilled birth attendants, and that's what the government is doing. Engage skilled birth attendants, training and retraining of birth attendants on the prerequisite knowledge and skills for doing so when mothers come for birth or for child delivery. And also that we also need to ensure that we prevent anemia when women coming for ANCs that are properly cared for. And so that when they're going for deliveries, they'll not readily run into blood shortage and also anemic conditions. In other words, providing proper antenatal care for women regularly and also with purposefully can also help to address some of these things. Since during antenatal sessions, we also provide health education messages for the mothers. And besides, where the husbands or the spouses of our women also come to support their wives during antenatal care, we also use opportunity to educate them on the things they need to do, safe sex during pregnancy, and also ensuring that the communities also adequately participate when women are pregnant in case emergencies arise. And then, aside from this, I also want to let us know that we need to create linkages between the three tiers of health practice, the primary, the secondary, and the tertiary. And as I'm speaking now, at the national level, in the course of what they call the PSC revitalization, a lot is ongoing. A lot is ongoing that I want us to take home. In the course of the PSC revitalization, there's going to be improved infrastructural development. Currently in deltas and across the 774 primary care centers in the country, this has already begun. At the national primary care level, they are handling it at different fronts, from what you call the Basic Care Provision Fund platform, the Impact platform, and also the various state governments are also doing this in addition to individuals who have come up to adopt health facilities. And it's not just developing, improving infrastructure. It means that we must be purposeful. We need to provide 24-hour services for our mothers and all others who need health care. How do we mean that the intention of government now is that it must be the case that primary care centers provide 24-hour services? And this means you need to provide residential homes for the health workers who come there to work, providing necessary incentives. And then also on the aspect of improving the skill of health workers, the government has deliberately and purposely come up with what we call the midwife service scheme and also community health extension worker service scheme. And then this will need to be trained and retrained. Again, too, the government is also working with institutions for developing curriculum, improving the curriculum. And then not too long ago, the president also came up with this initiative of training health workers across the country on the various things they need to know in the different programs that they carry out, be it malaria, be it immunization, be it HIV/AIDS and all of that. And so at the primary care level, what we're doing is not only tackling the issue of postpartum hemorrhage for mothers, but also looking at all those other things that could be risk factors, proper health education, getting the communities involved. And then besides to the government at the primary care level, is also thinking strongly and beginning to work on the area of emergency care. In some of the states in the federation that they've currently deployed what they call keke napep ambulances to take women or anybody that is in need to referral facilities. And then the current design of the primary care system is also moving up in such a way that health facilities are now going to be upgraded from type 1 to type 2. And then for those who understand the hope and scope approach of the HIV program for catching patients, some of these facilities are going to become referral centers. We'll be able to provide better care for them. And then, like I also said earlier on, in the course of the PSC revitalization, the federal government is also trying to see, with the collaboration of governors, the Governors Forum, honorable commissioners of health all over the country, to ensure that we now have a good complement of health workers across the country, which means that in the nearest future, Nigeria will be having this experience of having doctors, nurses, pharmacists, laboratory technicians, or laboratory officials doing their job in all the primary care centers across the country. You agree with me that this will in every way improve the quality of health care that the country is providing. And let's just go to the next slide. Next slide. And then government will also provide essential drugs. What the Delta State government is currently doing is that through the contributory health scheme, individuals, those who are not civil servants, are required to pay just about 7,000 naira to be enrolled. And then the rest is subsidized. 7,000 naira for the whole year, and the government subsidizes all of that. And so people now have access to care in almost all the 25 local governments of the state. All of them, not just almost, all of them. And then this also includes secondary facilities and primary care facilities for the purpose of synergy. And then also, we are not forgetting the fact that in the spirit of primary care, communities are not left out. In our various plans, work plans, and we develop, we ensure that the work plans are done as a matter of a bottom-up approach, so that various individuals and stakeholders contribute to make it meaningful. And you agree with me that we are driving towards achieving the universal health coverage. And as we do so, it cannot be done by one single individual. This is where we call for building linkages, ensuring that when patients are referred, the higher centers receive them appropriately and also provide the needed support and care. My dear friends, I want to thank you very much. I have some other engagement to attend, but I once again want to appreciate all of you who have put this together. We know, as the topic or theme says, that health is on the government agenda. And that's why I've taken time out to educate you and also to inform us about some of the things that are happening now at the primary care level. We are very, very hopeful that in the nearest future, Nigeria will be better for it. And I'm also hopeful that as we march towards attaining universal coverage, everybody will be there. Everybody needs to make input. Thank you and God bless.
Thank you very much, Dr. Yukore. That was a wonderful presentation. And thank you so much, sir, for the way you really brought out the role of primary health care in preventing and managing PPH in Delta states. We want to really appreciate you. So I would like everyone on the call, you can put in your appreciation on the chat box for Dr. Yukore. That was a wonderful presentation. So right now we'll be taking questions and comments. I see that we already have some questions. So in case anybody has questions for Dr. Yukore before he goes off the call, it would be good for us to ask the questions now, so we can show our appreciations on the chat box for our wonderful presenters, the first two, Dr. Wayemi and Dr. Yinkore, for that wonderful presentation. So if we have any questions for Dr. Yinkore, please, I think this will be time to ask him the questions, but then we have some questions on the chat box already for Dr. Wayemi. And so I'll just read the first one, but if we have any questions, please, we can just raise up our digital hand. I'll recognize you. And so let me ask Dr. Wayemi, please. You have a couple of questions on the chat, so I'll just take the first one. And so we have a question here from Dr. Uche. She says, this is directed to Dr. Wayemi. She's asking, do you think the free maternal healthcare program in Delta states has helped curb maternal mortality? And then she's now asking, Are there statistics to compare before inception of the program and after? What's your own idea on that question, please?
All right. Thank you very much for that question. I most definitely think that prematernal health and child health in Delta State has helped considerably reduce the maternal mortalities that we have in Delta State. However, it's been on for over 12 years now, thereabout, and I cannot categorically tell you what the data spoke to before the inception of free maternal health. But I can tell you that even it is so prematernal health across all tiers in facilities is so people are drawn towards it, not just even Deltans. We have our neighboring states coming in from Onitsha and the east. Even sometimes from Edo State, we have people coming in to access free maternal care. I do not, I cringe to even think of what it would have been if there was no free maternal care in Delta State. I believe that indices would have been much worse than it is now. But I can tell you that free maternal care is not perfect. We still have a lot of issues. We still have a lot of gaps. And those gaps, you know,
Sorry, it's like you're muted, Dr. Oemi. It's like you're muted.
You're muted, ma. Dr. Wayne, we didn't get you.
Hello, Dr. Oemi. I don't know if you can hear me. You were muted for like last 30 seconds of what you had to say. We didn't get you, please.
hello, I don't know if you can hear me.
Yes, we can hear you now. So for like the last 30 seconds, we didn't really hear what you had to say, please.
Hello.
We can hear you.
In the last 1 minute, ma, we lost you. We didn't get you.
So probably I think maybe she has some network issues.
Okay,
Maybe-
yes. Sorry, I'm back. I don't know if you heard
Okay.
my answer.
Yeah, so like towards the end, let's say Dr. Wayemi, so it's, I don't know, probably network, but maybe while we're
You
trying
said
to okay.
so. I
I
said
said
in
in
answer
answer
to that
that
question,
question,
it's a
it's a resounding yes.
Okay, so it's like you're muted again, but
Hello.
probably yes, we can hear you now. No, we are not hearing you. You're muted.
Muted again.
Okay, so maybe
Can you hear me
Dr.
now?
Oye, yes, we can hear you now.
Hello?
Yes, we can hear you. Oh, but you can't hear us from the way you're shaking. It's like you can't hear us. So probably we'll get back to you. Get back to get your own opinion on that question. But I see that Dr. Yinkore has a question. So I'd like Dr. Yinkore to address that, and we'll come back to you for the remaining two questions that you have. I don't know if you can hear me, Dr. Wayemi. We'll come back to you to get your opinion on the remaining questions. But Dr. Yinkore, sir, please, you have a question on the chat box. And it's from Dr. Uche. She said that primary healthcare forms the basic unit of all healthcare systems. That is usually the first point of care. So she would like to know, what are the modalities that have been put in place concerning training of support staff and materials for management of PPH? Because these women that come to the PPH, they come with little or no. Okay, because the women that come from PPH, they come with little or no intervention. So she wants to know, what are the plans in place for training of support staff and materials for management of PPH?
Thank you very much. I hope you can hear me.
Yes, sir, we
Can
can
you
hear
hear
you,
me?
sir.
All right. Let me just go back memory lane. So much has been done by government. Even when I was presenting, I mentioned earlier that not long ago, I think just about 2 weeks now, the Delta State also concluded the presidential initiative of training health workers, building the capacity of health workers on delivery of primary health care services. But aside from that, too, you also remember Dr. Wayemi told us about the training of consultants, doctors from hospitals, and also for primary health care centers. Yes, even at the primary care level, this was done not long ago, I think about 3-4 months back, especially on the areas of life support and also the engagement, the issue of engagement of qualified manpower. Before the last government left, there was this program, they call it Sudani Project, in which the government trained and deployed doctors, nurses, community health extension workers. Can you hear me? Hello?
Yes, sir.
Yes,
We can
yes,
hear
sir,
you,
we
sir.
can hear you, sir.
The government trained doctors, community health extension workers, nurse, midwife. That project is ongoing. And the government is paying, even the Delta State government engage some of those. For instance, from my office, we are paying them. We are paying them on a monthly basis. We're also thinking about, also sent memo to His Excellency to see how these people can be absorbed into the full civil service. So they'll have entitlement to retirement, to promotions, and all of that. And then that is to also remind us that those trainings for those health workers, we're not just deploying them, but you also develop protocol. What are they expected to do? Over the years, the government also, in the course of coming up with the midwife service program, provided commodities for those nurse midwives to work. There's one they used to call Mama Kit. If you go to our health facilities now, you may see some of those kits there. As they were deployed, they were also given the commodities to go and work with. And then again, 2 years back, we're also working with what they call the Delta Oil Producing Areas Development Commission. They also provided equipment. What are those equipments? Beyond just beds and mattresses, it also provided what do you call delivery beds and all of that to strengthen maternity services. And then also other equipment is provided, forceps, those delivery kits were also provided. And then from time to time, government reviews the protocol for those of you who are working in Delta State, you agree with me that the primary care is not just working in isolation. We are making sure that commodities such as drugs and consumables are centrally purchased and centrally distributed. And our commodities are coming from the essential drug, what I mean, the DRF in Delta State, which has also, in collaboration with the State Contributory Commission, developed what do you call essential drug list. Essential drugs that are being provided. The ones under the contributory scheme, those drugs are there. So you can imagine in the whole of 12 months in a year, 365 days, assuming somebody falls ill of different illnesses about 7 times in a year, we may say that person is right so long as there are no complications. But then you know too well that times the person goes for treatment, he will pay a lot from out of the pocket. And so the government has absorbed that out-of-pocket expenses by enrolling and also paying for the money that others cannot pay. So that one is also ongoing. And then I also mentioned that this PAC revitalization also addressing some of those other issues like ensuring that the health facilities are well equipped, and also there is provision for residential, housing for the health workers so that they can provide 24-hour services. You also remember I mentioned that the federal government is also doing what they call verbal autopsy now to improve what you need to know, that during the antenatal care, what are the things somebody needs to know, not only wait for when disasters happen. Verbal autopsy and also the issue of referral, all of these things have been addressed. I will not be able to just recount all of the things that government has done in a jiffy, but I want to reassure you that the government is doing a lot. Okay, government is doing a lot, and protocols are being developed. We're also working recently. One of the institutions in the state, the one they call Ogume, Novena University Ogume, is also working with the Primary Healthcare Development Agency, where in the course of training nurse midwife, they send them to our facilities. We're also providing IT services for these students as they come. Personally, when the list was sent to my office, we deployed them to all the functional PSCs across the state, and the ESCs too, who are doctors at local government level, are also helping to address the issue of leadership. And then, because, like I said, we are not working alone. There have also been times where we've been working with the Obstetric and Gynecology Society of Nigeria. And not only that, my friend, Onyowa, my bosom friend, I want to also appreciate you for putting this together. This is the second time you are calling me to do such presentation. And we have also been working with a Pediatric Association of Nigeria, the surgeon. So everybody is welcome. And that's why I talked about this issue of building linkages. And that for us to attain the universal coverage, we must do it collectively. Everybody must contribute to make it work. Thank you. Thank you.
Thank you very much, sir, for that wonderful
awesome.
response. Thank you,
Thank
sir. We see from your background that you're also very busy where you are. We appreciate the commitment, sir, to during this presentation, even with your very tight schedule. We really appreciate.
Thank you.
Sir.
God bless you.
Thank you very much, sir.
Thank
yes,
you.
sir. So we'll also like to, for those that are not joining us, we just finished the 2 presentations, and we'd like to also use this opportunity to specially welcome Dr. Chinyere Amaka. She's the chairman of the Medical Women's Association of Nigeria, MCH Committee. You're welcome, ma. We also specially welcome Dr. Ifeyinwa Okeke. She's the MWAN National Outreach Committee chairman. We welcome you. We wish we could send you starch and banga, but we appreciate you. Thank you for having you on this call. And Dr. Wayemi, on your back, network is now your friend. So we just have one question for you before we introduce our next speaker. And that question was asking about the availability of the stockings, the pneumatic anti-shock garments. So the question was, is it still in use and is readily available in our facilities. So that's a question for Dr. Wayemi, please.
Okay, thank you very much. Sorry about that. Anti-shock garments are still in use. In fact, more research is coming out every day on how effective these anti-shock garments are, with reference to helping, promptly transporting a woman from a PHC or a facility that cannot, manage her to a more a higher facility, like a secondary or tertiary facility. The government, the Ministry of Health, is in the process of procuring anti-shock garments. However, anti-shock garments are quite expensive, and secondary facilities, private facilities are encouraged to procure these garments. We can give you contacts of persons that can provide those garments at subsidized rates. And I'm hoping that we, in the next few months, can say that we will have begun the rollout of anti-shock garments, as well as training of primary healthcare facility health workers on how to use them, because we believe that they are the ones that need them the most. So over, thank you.
Thank you very much, Dr. Wayemi. We appreciate that response to the questions. We appreciate that. So we're looking at our time and we're trying to see how we can make sure that everybody has the opportunity to present his or her own topic, and then we also have all our various questions answered. So I would like to, at this point, introduce our next speaker, and he's someone that we have already read his citation, and he's someone that every presenter kept referring to. So we have Dr. Sunday Jumbo. He is the current head of department obstetrics and gynecology, FMC Asaba. He will be here and he'll be talking on the physician's role in preventing and managing PPH, challenges and opportunities in Delta State. He is the author of so many articles, both national and international journals. And we are very glad to have him give us this wonderful topic as we commemorate this day. Good evening, sir. Dr. Jumbo, sir. You're welcome, sir.
All right, good evening, everyone.
Good evening, sir. I'm hoping you can use 15 minutes, sir. I know your wealth of knowledge, but then we appreciate you, sir. 15 minutes. Thank you so much, sir.
Okay, thank you. All right, good evening, everyone. MWAN privilege. Wonderful time to really come and speak when it comes to this. It's our passion to say that no woman will die of it. So thank you, Lord. Thank you for this privilege. So just because of our time, I would like to mention that we look at distance growth, strength, and manage postpartum haemorrhage. I will look at the challenges and the opportunities of Delta. Much has been said about age definition, but fundamentally we know that it's bleeding from the genital tract after the excess of 500 following vaginal birth or 1,000 following a cesarean birth. Because of the challenges with this definition and how it can be diagnosed, health authorities have been looking at anything better. So American College of Obstetrics and Gynecology decided to come up with a more recent definition when there is basic blood loss after birth, excess of 1 liter with symptoms. And then some are saying it might be difficult to really visually explain blood loss. Can we try to see if we can use difference or factable difference from the time the woman was admitted in labor, and then after the when there was, if there is a difference, excess of 10%, means that the patient has postpartum hemorrhage. However, others are looking at that this patient is carrying that any blood loss after birth that is significant enough to cause both an instability and term as what postpartum hemorrhage. Imagine a woman coming with a baby, but by the time he lost a little amount of blood, he would have compensated. So it's suffice us to say that postpartum hemorrhage is a major cause of maternal mortality worldwide. Just like the first presenter has quoted, statistics is still there that each year about 40 million women experience postpartum hemorrhage, and this results in about 70,000 maternal deaths globally, and that represents about that.
Good evening, sir. So sorry to barge in, sir. Please, the audio is a bit poor. I don't know. Maybe if you could just adjust your position or something.
Okay,
but the
can you hear me now?
It's not too good, sir. Oh, fine, better now.
Okay.
Thank you, sir.
Is it
Thank
better
you,
now? Okay, fine.
It's
Thank
better
you.
now, sir. Yes, thank you.
All right, thank you. So the burden is so much that within 4 to 6 minutes, a pregnant woman dies of BPH following what? Delivery. However, it's important to know that even when the woman survives, maybe by way of PMS, they will definitely need urgent surgical interventions to control this bleeding. And this, to a greater extent, left these women with lifelong reproductive disability. One thing that is very clear is that the causes are well known. And the effective things or treatment modalities are well known and they are valuable. Yet, BPH still claims our mothers in their prime. So both in the well-developed and the low and medium income countries, BPH is still a major challenge. So physician has a major role to play, as this requires, as they are very much required during prevention, in early diagnosis, and appropriate timely treatment. We look at universal health coverage, which is the thing we are celebrating today. And essentially that people should have access to essential health services without having financial hardship. And it has these 3 pillars or goals: aim to improve health outcome and reduce financial burden on individuals and families. And the last one is increase access to essential health services. So BPH is one of these things that is highly needed, that can be supported greatly with the universal health coverage, even as we march towards achieving it by 2030. So it's important we know this pathophysiology of postpartum hemorrhage so that it will guide us on looking at where are the challenges and where we'll be able to maximize the opportunity. During the course of pregnancy, the pregnant woman acquired increased plasma volume or blood volume that causes some degree of hemodilution of pregnancy. And then after delivery, the uterus contracts. That contraction creates a natural ligature such that all the blood vessels across the placenta bed are now constricted. By virtue of that constriction, there will be platelet aggregations and clot formation. So it's important we know that uterine perfusion at term is about 700 to 800 mils per minute. That's the perfusion to the uterus per minute. So that tells you the degree of blood that goes to that uterus, peradventure that the placenta bed is not covered, it's not properly clotted. You will now see that a woman can lose or exsanguinate within 10 minutes. So it's important to say that time is critical in the care after placenta separation. The risk factors, you can look at it as they are. It's good to state here that there are a lot of risk factors for postpartum hemorrhage. And it's important that these are identified during the course of the antenatal care. But suffice it to say that despite these risk factors, a lot of pregnant women after delivery has no identifiable risk factor, yet they still develop what? Postpartum hemorrhage. So it's drawing our attention to see that every woman at delivery should be anticipated to have the risk of what? Postpartum hemorrhage. Because of our time, the causes are well known, just like we said, the 4 T's, but know that the tone, which also is replicated here as uterine atony, that's poor contraction of the uterus. Remember, we said without that contraction, the natural ligature will fail, and then the bleeding will be precipitated. So many things can cause them, as we see them listed here. But the commonest of it is uterine atony, which occurs in about 70 to 80%. And then trauma, whether from delivery or from lacerations, and then tissue, commonly from retained products and possibly membrane. And then thrombin, we can call coagulopathy. So prevention is really the key. And when we are talking about the prevention, it stands from having a good antenatal care. We cannot jeopardize it. The importance of good antenatal care in preventing postpartum hemorrhage cannot be overemphasized. And part of it should include that every pregnant woman should have iron and multivitamin supplementation. And thank God we have the dietitian in our midst. I'm so glad that it's part of this presentation. So you will elaborate more on this so that you will see that it's not essentially this supplementation, but the diet which our pregnant women takes is very, very paramount in trying to give them good outcome. And it also talks about the child that is to come and in his or her future neurodevelopmental milestone. And then I have to put this one in red just for emphasis on skip birth attendants. I'll discuss it in subsequent slides to tell us that the role of skip birth attendants at every delivery should not be overemphasized. It's very, very paramount. And that should be the bedrock as we are moving towards achieving this universal health coverage or preventing primary postpartum hemorrhage. And then the active management of third stage of labor. This is the key to prevention of what? Postpartum hemorrhage. And it includes administration of oxytocin after the delivery of the baby. You know, initially we are talking about delivery of the anterior shoulder, crowning of the head. Further evidence has shown that the ideal time is after the delivery of the baby. And the uterus has been checked and assessed that there's no other pregnancy or any other baby in the uterus. And that oxytocin is 10 international units that can be given intravenously or given intramuscularly. And then the next one is controlled contraction and then uterine massage. Then the last key thing there is 4th stage. I call it 4th stage of labor. I quote, because it involves the first 1 hour after delivery and includes close monitoring of blood loss after birth with the use of drape, which is a great innovation and has been adopted by the Federal Ministry of Health. And then strict monitoring of the vital signs and continuous uterine massage of that patient for the first 1 hour after delivery. With this in place, no woman should die of what? Of PPH. Now, treatment. I said PPH is a life-threatening emergency. So it therefore requires ABC of resuscitation. And then initially, when we were in undergraduate or in residency training, we are talking about sequential approach, such that you assess the patient, you raise an alarm, you make sure she's breathing, you make sure that there's airway, you make sure there's circulation, and then assess the uterine tone, which is the commonest cause. If there is no contraction, adequate contraction, you administer oxytocin and continue uterine massage. And then you can use tabletocin, you can use possibly misoprostol as the case may be. And then the women trial that I've recognized from research to show us that the role of tranexamic acid, giving 1 gram within 3 hours of diagnosis of postpartum hemorrhage. You see the essence of time in the management of a pregnant woman that delivered and at risk of postpartum hemorrhage. And then do a thorough examination. If the contraction is not optimal, you can do intrauterine balloon catheter insertion, you can do bimanual compression, you can do aortic compression. And then the last stage, we are talking of laparotomy, possibly with hysterectomy. And then further technology, the use of uterine artery embolization, and possibly uterine artery ligation. So this is the previous sequential approach. However, with the current best practice, we can see following the World Health WHO adopting the use of emotive bundle. Suffice me to say that this trial was a research that was conducted in Nigeria. And then it involves a lot of centers in Nigeria, in Tanzania, and in Kenya. And this outcome was quite remarkable, showing that using a bundle approach helps in reducing mortality, reducing postpartum hemorrhage, and possibly the morbidity and mortality that are associated with postpartum hemorrhage. So we find out that it is highly effective in reducing death from PPH for up to 60%. And this has been adopted by the Federal Ministry of Health and has been incorporated into the national guidelines for the treatment of postpartum hemorrhage. The beauty of it is that it's easy to administer by all skill bed attendants. Now, the bundle is very clear here. The E stands for early detection of postpartum hemorrhage. That is trying to make early diagnosis and involves the administration of what? A calibrated drip. Once the woman has delivered, the placenta has been delivered, a calibrated drip is somehow this man is full of alcohol. But with this calibrated drip, you detect exactly where God has got 500 mils. And at that stage, of what? Postpartum hemorrhage. With that assessment, there is a trigger of what called motive and this bundle called WHO first response bundle. And it includes M there, meaning massage to assess traction and to sustain traction. And then administration of drugs. And then kind of collect sample, open and match, examine patient, and if there are lacerations that are there, if there are evacuated, and this can be done by every single attendant. And paraventure bleeding continue, and what we can name refractory PPH is an escalation for either the center and not the patient can appropriately transfer higher than health. So physician's role, we can say here, I want to clearly state the field best attendance. It is important we say physician's role, but as it pertains to maternity care, where we are simply based on the presence of the field best attendance. And what is this best attendance? Say if a healthcare professional, either a doctor, a nurse, a midwife, or an obstetrician, it's not a traditional birth attendant who has been trained to proficiency in the act of managing normal labor and is able to recognize complications, either treat it or refer promptly for expert management. So you see, this gives us a lot of opportunities that you have possibility of an enlarged manpower that should be able to help in this prevention and treatment of postpartum hemorrhage. So physician's role is a strong pillar. And we have seen that the presence of a skilled birth attendants, in addition to emergency obstetrics and newborn care, are the two strong pillars in reducing maternal morbidity and mortality. So the physician's role involves providing quality antenatal care, quality prenatal education and counseling on iron and multivitamin supplementation. Like in our area where malaria is endemic, the administration of intermittent prophylactic treatment for malaria, and then advocates for balanced diet and child spacing. Our mothers around here, they come in with pregnancy within 1 year, and that's time they have not really accumulated enough. They are already at a deficit. They are anemic. And so with good child spacing, we should be able to help to prepare this woman properly before labor and delivery. And then during the course of the antenatal care, it's the role of this physician to assess risk. Usually we talk about low risk and what? And high risk. Peradventure, this is a big challenge we are facing. That majority of our health centers, you see them accommodating high risk pregnancies and refer when there is problems. At that antenatal care, patient needs to be appropriately assessed. And those that are low risk can continue care and those that are high risk can be appropriately referred. And timely referral is very important. It's very key in our attempt to be able to safeguard these patients. And the next thing there is bed preparedness and complication readiness. People always say pregnancy is not an emergency. It takes about 9 months, as the case may be. So there's enough time to prepare. And in the path of that preparations, there's a time to be able to prepare for complication. Complication can arise at any time. So every pregnant woman and his family should be guided on this by the physicians. So for the physician's role, it's still important. They stay up to date with evidence-based practices. We need to be well updated. Things are changing rapidly as the science, as the research are coming in an attempt to improve quality care. So all the physicians need to be well updated, basic evidence, best developed evidence for practice. There's require training and retraining. What I termed PPH drill. Every maternity unit, you have a drill, just like do rehearsal for song. It's important because we can't predict when PPH will come. So it's good that everyone is trained, even new recruits and those that are being transferred from one unit to the other. It's important they be trained and retrained on the drills of PPH care. Another important thing is good referral and transfer network. You can't say you're transferring a patient that is PPH and there's no communication to the other center. It's important that the physician has this as a paramount role to be able to make provisions before transferring and then make provisions for speedy transfer, that with ambulances, network services, that will be able to help the patient to arrive at the center. Multidisciplinary care and collaborations, these cannot be overemphasized. That we need the anesthetists, we need the surgeons, we need other healthcare staff, the nurses, even porters, all this that can help, and the drivers all put their hands together to see that save women's lives. So it's important they involve also in innovative and implementable research. Research is key, just like our first presenter has stated. I'm impressed with the research he has cited, and all these research are locally done. It's not like the previously, when we just adopt guidelines from America, we adopt guidelines from UK, and then we are saying that is the national guidelines. No, this is patients that were used, they are all Nigerians. So it's a peculiar work. So it's quite innovative that we need to still emphasize this, and most physicians need to do more in innovative research. And we should stand as advocacy, both to the government, to NGOs and communities. Now, what are our challenges in PPH care? You see, there's lack of skilled birth attendants, both in the rural areas and urban areas. You see, there's disparity. A lot of skilled birth are in the urban areas. But the rurals, this is where primarily that these our patients, they present. And it's difficult for them to be transferred from that rural place to the urban place. So there's need for us to train and retrain, thanks to the Director of Primary Healthcare Development, showing efforts that is being made to see that the rurals are not left out of this goal. So it's a big challenge for us. Limited resources and infrastructure for health. Then limited access to emergency service. We talk of our road, talk of an insecurity, talk of ambulance services. This is very, very important because PPH can occur at any hour of the day, just like the primary healthcare coordinator is saying, telling us of the essence to make provision for every pregnant woman for 24/7. Any facilities that entertain taking care of a pregnant woman should make provision for her care 24/7. So it's important, roads should not debar us, integrity should not debar us, and there should be adequate transport route to be able to transfer these patients from where they are to where they can get better help. A very big challenge is for cold chain system for oxytocin. Just like we said, oxytocin is heat labile. It requires refrigerations. So the cold chain system is what ensures heat potency. But this is a big challenge for oxytocin. So others oxytocin, like apetocin, like misoprostol, they are heat stable, and then but the cost is much, and they are associated with side effects. However, oxytocin is still the gold standard. It is important we improve on the quality cold chain system for it. And delay in diagnosis, just like we rightly state, diagnosis is different, how to assess the blood loss when the woman has delivered. But with the use of calibrated drip, I hope this will go a long way. Our social, cultural, and religious barrier. This is very, very paramount. Just like we mentioned the traditional birth attendant. It's not that the people are not ready to go, but by their culture, it's what they have been invited. So we need to really study them. We need to look inward why they are there and how we are going to be able to detach them and see that they are able to come out from that TBA services or be able to come out of the cultural delays and be able to present themselves for care timely. And then high cost of healthcare. Thank God for the universal health coverage, which we are projecting to get to 2030. We still have a long years to be able to achieve this. That will help to reduce the cost and the burden of healthcare or pay out of pocket pay for healthcare services. So we look at the skill birth attendants also, their training and retraining is a huge challenge. Now, the ultimate is inadequate blood and blood bank support. Obstetrics, we say, is a bloody business. There's no way you can run a maternity service without a blood or blood bank services. This is a huge, huge challenge for us. And we hope that this should be critically looked into. And there are a lot of opportunities for us as we go to the next slide. Then poor data and research activities. PPH, there are still a lot of research gaps. So we try to see how we can improve on that. The next is the opportunities we have. So look at the universal health coverage, the targets. Now, the primary target is primary healthcare base, which is very close to where these people are. I could remember the time of Rusin when he was talking about who is the godfather of this primary healthcare. There was a recommendation for a comprehensive health center and a primary, that's in every community, that there should be one comprehensive center that is to serve other primary healthcare centers so that they will be able to have good access. So as we are moving with the direction of the National Primary Healthcare Unit and then the Federal Ministry of Health, and then this focus on the universal health coverage and the national health are trying to come down home to where these patients are. It is good we maximize this opportunity. And now that the local government has been empowered and they have a direct funding for the federal government, I think it's a good thing to buy leap into how we'll be able to maximize this potential of raising further funds to care for primary health care services. Thanks to Delta State Free Maternity Care, it's a huge step in the right direction, but we still need health system improvement. We need staff, and we need to strengthen good referral network in terms of ambulances, in terms of anti-shock garments, which will give a temporal stabilization prior to the patient getting to the appropriate treatment site. And then we need to involve in data collection to inform decisions. It needs review. I say it's about 10 years. We need to review it. Where are we now? Is there anything we can do better to see that we improve the quality of service that the patient gets? And then listen to these patients themselves, get their feedback, get feedback from our centers and see where we can get it improved. Now, on the blood bank and blood products, it's still very, very important we look at this. With respect to, I need to really congratulate the state also for our subspecialist hospital having an arrangement where these blood and blood products can still be made available. So it's a huge development, it's a huge progressive milestone in an attempt to address these challenges. So we are not talking of whole blood. Whole blood is necessary, but we still need some fractions of those blood products, especially fresh frozen plasma, cell plasma, and platelet concentrate. Just as we said, in causes of PPH, not necessarily atony. For those that are trauma, for those that are because of coagulopathy, those products are highly needed. And we go across to source for it, and patient has to pay out of their pocket. But with this closer to us, I believe it's a step in the right direction. And look at the National Blood Transfusion Act. It's no longer National Blood Transfusion Service. It's now act like the National Health Insurance, such that every state should be able to have a domicile blood bank services. So we need to key into this national program and see how Delta State should be able to have a national blood transfusion unit that should be able to provide blood services to as many that would need it. And also, we need community to be mobilized. Most times you see patients, you are referring them, we can talk to them, call your brother, call your sister, call your relative, as many that are healthy that can donate blood for you, because that might be a life-saving tool. It's most likely you are losing blood, you need to replace that blood. So look at FMC in my center. We have a blood donation policy that can be adopted. Look at it critically in the right sense that every pregnant woman registering for antenatal care should be able to donate 1 pint of blood as part of her preparedness to delivery. And it has been a life-saving tool for us in being able to have a lot of blood services. We need to review it, we need to upgrade it, we need to sustain it. And then looking at the national guidelines on PPH prevention, we need to domesticate it. Thanks to, I was part of the training, just like the first presenter mentioned, and it's important, we need to domesticate this to see positive results. The study was so unique that after full implementation of the research with the publication, there is a backup from donors and partners to be able to sustain the implementation. This is one of the unique studies that we have seen so far, converting science to what? To implementations, that people will begin to benefit and eat the fruit of what? Science. And then the application of DRIP.
Hello, sir. Hello? Sorry to interrupt you, sir. Yeah, we have about 5 minutes, sir, please.
All right, so I'm rounding up. So we are there. So we need to improve supply chain for effective and potent oxytocin. Yes, we are talking of abetocin, but it's very costly. So cytosine is still called what? Effective. And it's available, it's cheap. The only defect is just the cold chain system. So from the DROF, we need to sustain an effective cold chain system to see that this will be sustained. So we need more in research, we need more in collaboration, both local and global partnership. And that's what you can see in the outcome of these 3 effective research that we have seen revolutionizing PPH care, the women trial, the emotive trials, and the champion trial. All these are studies that were done with partnership and collaborations, and we hope that more should be done. So we need to initiate a mother incentive for fertility delivery. Just like we talked about the TBAs, it's difficult for them to detach. But if we can go with this idea, which has already been in place from the Federal Ministry of Health, that this can be adopted to see that those pregnant women coming to a facility to deliver receive not just free maternity care, but should receive something as an incentive for coming. And they will go home to tell others, and you will see that the increase there will be a progressive increase in access to care. So in conclusion, just because of our time, physicians play critical roles in preventing and treating PPH and must stay proactive in order to avert deaths of our mothers in their prime. So most important is good antenatal care, so that we should have early diagnosis and appropriately time treatment. It's very, very key. So all efforts should be geared towards this universal health coverage of 2030 for access to quality essential health services at the grassroots. So we need to domesticate the national guidelines for PPH, and then we should have priority for training of skilled birth attendants that are backed up with essential drugs and necessary equipment supply. So these are a few references I have, and I want to say thank you for listening, and we'll be glad to hear your questions. Thank you.
Thank you, thank you, thank you so much, sir. That was a very wonderfully delivered presentation. So we're so grateful. For those of us that listened, you can agree with me that that was a very wonderful presentation from Dr. Jumbo. So we really appreciate that presentation. Please, anybody that has questions, you put it on the chat box. We're going to be going straight to the next presentation. And I'd like to thank everyone for being patient and being on the call. You must agree with me, it's very interesting. And we know that we are in for a wonderful ride this evening. So I have the pleasure to introduce our next speaker. He's somebody that is very well versed, experienced in his field. He's Secretary Sodo. He's a representative of the civil society scaling up nutrition in Nigeria. He's going to be talking to us on nutrition and PPH, critical link and implications for universal health coverage in Delta State. He's somebody that I've known for many years, and I'm happy to have him here on this call. So, Mr. Odo, you're welcome. I hope you can discuss this in 15 minutes with all your wealth of experience and knowledge you have as it pertains to nutrition. You have the floor, sir. You're welcome.
All right, thank you. Still standing on the existing speakers, Dr. Wade Francis, Dr. Inkore, and Dr. Jumbo for lighter and shorter, because the issue about PPH and my own topic says nutrition and postpartum hemorrhage, the critical link and implication for universal health coverage. Basically, I'm going to discuss it based on, we're going to look at a brief about the CSON, the vision, the mission, the aims and objectives. Then the universal health coverage, we might not talk about it because some of my they have data about on it, and we are going to look at the PPH, a brief talk about it, and we talk about some of the nutrition and nutrition-related consideration when we talk about PPH. A brief of it, the civil society, CSON is a non-governmental, non-profit making aimed vision. And the vision is a country where citizen is food and nutrition secured. Food and nutrition secured underlined. And the mission of CSON is to mobilize non-state actors to advocate, generate evidence, and build capacity and stimulate communities to scale up ownership and sustainability of nutrition in Nigeria. There are many aims and objectives, about 6 of them, but I will look at the number 3. Next slide. And the number 3 is to advocate and engage governments to create line in some key federal, state ministry, and local government council in Nigeria, as well as include CSOs in nutrition interventions as appropriate. Next slide. To ensure and strongly advocate for establishment of an effective and functional nutrition surveillance monitoring and evaluation system at all levels. In CSON data, we're almost stepping down what the national is doing, making sure that nutrition is created. The budget for nutrition is created in different ministries, be it at the state, be it at local government level. And we're equally integrating with other nutrition, other bodies like State Committee on Food and Nutrition to make sure that some programs that are really focusing on helping to reduce malnutrition, that we are helping to integrate them. CSON data has been working with State Committee of Food and Nutrition to make sure that different nutrition interventions, be it the support exclusive breastfeeding and continued breastfeeding, be it the multiple micronutrients so carried out by our mothers. CSON data has been meeting with different stakeholders, even our speaker, the director of primary health care, to make sure that some of the nutrition, food and nutrition policies that are being championed are being domesticated in the state and the local government level. Now, we are not going to talk more about universal health coverage. Next slide, because some of our speakers have almost discussed about it. We'll go straight to nutrition and nutrition-related consideration in PPH. Can you continue to this slide 10? Am I being heard? Hello?
Yes,
Hello?
yes, we can hear you. We can hear
Hello?
you.
Yes, we can hear you.
Hello?
We can hear you.
Hello? Okay. Okay.
We can hear you.
So we are looking at the and nutrition-related considerations. All right. And we are saying that adequate nutrition is essential role in promoting the health of both mothers and babies during pregnancy and even after the childbirth. And poor maternal health and nutritional status, they have been related to adverse birth outcomes such as PPH and maternal death, among others. Our last presenter was shared some of the risk factors or the causes of PPH, and I could see the BMI there. I could see the issue of anemia that he has been hammering for iron and multivitamin.
Oh, sorry, it's like probably network issues are like our presenter has been logged out. Okay, it's like he's on the call. But it's such Mr. Odo, you suddenly stopped speaking. It's like
I'm not.
you're on now. Okay.
I'm not on the call. It just went off.
Okay, okay. I
guess
think it's
it's from your end.
Oh,
I am on.
you're on. Okay, please continue then.
Can you hear
Please
me?
continue. Yes, we can hear you. Please continue.
Can you hear me? I think it's just it's not from my end. It's trying to.
Your network is not too smooth. It's
So I
it's fluctuating a bit.
The healthy nutrition therefore plays an important role in mitigating the severity of PPH and also in quick recovery, because one thing is to pass through the stage of PPH, and another thing is after PPH and the mother survives, how does can you hear me? Is this still fluctuating?
Oh, continue. I can hear you now.
No response from your end.
Please continue.
As I was saying, that the first thing is to pass through the phase of PPH. The mother has passed through the period of the phase of from that episode of PPH, and nutrition plays an integral role to that. And one of the nutrition-related factors that we are going to look at is the issue of iron folic acid or iron folic acid supplementation. Our two presenters talked about the need for iron. Dr. Nkore was talking about the antenatal healthcare services, the need for health talk, the need for mothers to attend antenatal, and during the health talk, they're supposed to receive, counseling, nutrition education. Then our Dr. Jumbo equally talked about the need for iron. And from our presentation, it's saying that maternal anemia in pregnancy has been found to predict the adverse of PPH. Equally shown that nutrition and health education and iron folic acid supplementation were positive means of improving mothers' health and nutritional status, together with the eradication of anemia. And improving maternal nutrition, such as IFA supplementation and hemoglobin level, will help reduce the chance of bleeding during delivery and possibly improve all birth outcome as a whole. the advent of MMS, multiple micronutrient supplements, has equally contributed in addressing some of these health challenges being faced by pregnant women during and even after pregnancy. Presently, before now, we've been talking about iron folic acid tablets as a supplement, but presently, the MMS is with us. At the whole health care facility, especially the primary health care centers, we are supposed to be seeing multiple micronutrient supplements. And it's one of the key nutrition-related intervention towards addressing the issues that are related with with pregnancy and taking care of the maternal health. And the Nigerian 2022-21 ministerial order permitted the use of MMS during pregnancy. This is based on the 2020 WHO recommendation on antenatal care for a positive pregnancy experience. And Nigeria was included in maternal nutrition acceleration plan. And they have almost received about 3 million bottles of MMS in 2024. And during this second round of maternal, newborn, and child health week, it is expected that all the primary health care facilities should be giving out multiple micronutrient supplements. The difference between MMS and iron folic acid tablets abound. Multiple micronutrient supplements have about 15 essential micronutrients, the minerals and the vitamins there, but for iron folic, it's just the two combination. So, and the MMS has other roles that it plays, because it's not just the iron issues that a pregnant woman or even expectant mothers are facing. They are facing other nutrition-related issues, like the issue that has to do with the zinc, the vitamin A, the vitamin B12, the folic acid, and that's why it has been thought and something that is worthy to produce, to be giving them this MMS. And the MMS comes in a tablet or in a bottle or in a pack of 100 tablets, and is not supposed to be opened. And this has been has been included as one of the essential commodities or essential medicine list for adults, and is supposed to be given free to every pregnant mothers as far as they attend antenatal. So one is that the MMS has been provided. Secondly, is that the mothers has to attend the antenatal to receive this. And it is said that this MMS is proven to be safe, effective, affordable, and cost-effective. And it's supposed to be taken, it is taken once daily. From the first, as far as the mother registers earlier, from the first day that she registered in the primary health care or the secondary or tertiary, she is supposed to be using it till she delivers. And even after delivering, she's supposed to take, because passing the stage of childbearing is not easy. And during the lactation period, she still needs adequate, and even to recover, for especially for the mothers that pass through the stage of the phase of PPH, they need adequate nutrients to replenish and to heal what they have lost. Next slide. This is just giving us other benefits of MMS apart from the provision of iron and the folic acid. The speaker talked, some of our health workers are not equally trained, and this is where we need health workers that are even trained in the area of nutrition to give adequate and complete nutrition education and enhancement. And according to the 2023 progress report, improving maternal and newborn health and survival and reducing stillbirth, anemia affects approximately 4.6 million pregnant women in Nigeria, with approximately 82,000 maternal deaths each year. And according to 2021 National Food Consumption and Micronutrient Survey preliminary report, only 34 pregnant women received nutrition and dietary counseling, which means that the remaining 56 never received the nutrition counseling. And out of the studies, the number of the people that we have studied, only 67% of them had IFA, iron folic acid. 44% pregnant women received at least one antenatal visit. 13% proportion of non-pregnant women of reproductive age consume the fortified food. And when we talk about fortified food, are food that are fortified with those essential micronutrients. So there is the need for healthcare professionals in the area of nutrition to educate pregnant women and women of reproductive age on the benefit of what? Healthy nutrition. Before you take in, we always hammer on the need for the folate or the folic acid to protect and to prevent the neural tube defects and other issues around the fetus, and even to prepare the mother for the pregnancy, and healthy nutrition after pregnancy, and to show that knowledge, one is to impart the knowledge and to make sure that the mothers make do with the knowledge that you've been giving to them. The next point that we are going to look at is unplanned pregnancy and nutritional stuff. Our last speaker was talking about somebody that is delivered, just delivered, after delivery, there's no plan for child spacing. Maybe it's delivering within a year, it's taking in. There is no recovery, there's no plan for all the healing process to take in, and it's taking in again. So there is this unplanned pregnancy and nutritional care can even cause poor prognosis when you talk about PPH. So the complexity of PPH is also due to partly because about half of all pregnancy are unplanned. And so most women are not able to build their nutritional stock before conception, which also predispose them to some deficiencies on the face of increased nutritional requirement due to pregnancy. Then obesity, is equally there. Aside from iron, aside from unplanned pregnancy, the obesity is there, and it has twofold increase in the risk of PPH. A high BMI increases the risk of atonic uterine hemorrhage rapidly, and the saying that BMI greater than 40 kilogram per meter square increases the risk to even 13.6 when it is CS, but 5.2 if it is spontaneous vaginal delivery. It therefore means that improved gestational weight gain, and pre-pregnancy weight are very important in reducing the adverse effects of pregnancy, and even the reducing the complication of PPH. Now, we are talking about the obesity. You find out that some of those that are, that are professionals in the area of nutrition and dietetics in the primary health care centers, you find out that the nurses there are very much overwhelmed. In some healthcare centers, you're seen doing almost everything. The antenatal services, she is the one running it. The routine immunization, only one nurse or one shoe is running it in a full building that is called primary healthcare. So how do you expect that one nurse alone to run the services and run it very well? When a mother that is having issue with nutrition comes, is it this nurse that will sit the patient or the mother down and start giving nutrition education? And for you to give a complete dietary counseling, at least you need nothing less than 30 minutes to be able to impart knowledge on that pregnant women. We just talked about MMS. There are guidelines for giving MMS. MMS is not just giving, if you see a pregnant woman, yes. Because if you do it like that, the mothers or the pregnant shows, we are told that yes, MMS, as you're giving it, the mother is supposed to be taking it once daily. And before you give, you need to give nutrition education. You need to educate on MIC, maternal, infant, and young child nutrition. You need to educate on hand washing and hygiene. You need to even assess for anemia, because if that pregnant woman is anemic, you don't give MMS. She has to go in for treatment for anemia. You need to even talk about the prevention of malaria. Our Dr. Jumbo talked about, giving SPs. You need to talk about the prevention of malaria. And they need to have mosquito nets. You need to even to evaluate for diabetes and hypertension. Before then, you cancel on diet before you finally give the MMS. For the mother to at least value it. Otherwise, that pregnant woman, will still go out and adopt that MMS and will be looking for pregnancy care. Will be looking for iron supplement. Why the one she's holding can solve the need for that the woman. And there's also
It's like we've lost audio. I don't know. Can we kindly confirm? Can we still hear him, please?
I can't hear him.
We're not hearing anything
Like the
anymore.
network has bouncing out.
Okay, so maybe while we wait for him to come back in, I see that he has just few slides to round up. While we wait for him to come back, I just want to appreciate everybody that is still on the call. We appreciate you for still staying on. And we want to especially recognize Dr. Ngozi Ali. She's a past M1 Delta president and also past National Financial Secretary. You're welcome, ma. Welcome every other person that is here on the call. Well, I'll just take some comments that we have on the group chat. And I think, okay, so while we wait for him to join back, I think we have a question here for Dr. Jumbo. Dr. Jumbo, sir, please, we have a question for you here on the chat box. I think maybe we'll just take that while we wait for Mr. Odo to come back and round up on his own presentation. So we have a question here. It's from Dr. Che. She was commending your presentation, and she said that during the presentation, you mentioned about giving incentives. Can you explain what you mean by incentives?
Okay. Thank you, Che, for the question. You know, we are looking at strategy in attempt to. Okay, it's coming back.
I am here.
Mr. Odo, all right. It's like the network logged you out.
So we are talking about age.
Okay.
It's saying that
Yes.
some.
Okay.
Yes, I have like slide to conclude.
Okay,
We are
continue, please.
saying that adolescent girls are still undergoing some growth at the time of conception. We'll see many. adolescent girls being pregnant, and some of them are feeling shy even to come out or even to access antenatal services. Some of them can stay one place, hiding inside their one roof till they deliver. So how do they even on the healthcare interventions that are being even packaged for them to make sure that they have a successful, period of the pregnancy and the childbearing? And experiencing additional nutrient need due to the developing fetus will predispose them to undernutrition, so PPH. So it means that healthy nutrition is in a pregnancy, healthy nutrition in adolescent is very critical. Then other nutrition and nutrition-related consideration is the need for dietary diversity. There is the need for all expectant mothers to meet up with the minimum dietary diversity, which is about 5 minimum dietary diversity, and consumption of different colorful food, healthy protein, fat, and carbohydrates, food rich in essential vitamins and minerals, and antioxidants will help in speeding up physical healing when they have passed through the phase of PPH, even reduction of postpartum depression, and equally boost milk production and supply after delivery, and build nutrition store before they even go to the theater for delivery. So there's need for our mothers to diversify their food. Looking at the 10 food groups, there is need to diversify to make sure that at least 5 out of the 10 food groups are being met every day. And when they do that, they will be able to get all the needed protein, all the needed iron, be it the non-heme and the heme iron that the body needs, all the vitamin C's, all the other essential nutrients that even help in protecting the body or protecting the woman, and equally in the healing process, and even in uterine contraction after the delivery. So there's need for the mothers to diversify. There's now the advent of some biofortified food. Some food are being fortified with folic acid, some are fortified with vitamin A. We have series that have been fortified with zinc. We have beans that have been fortified with the iron. So it's the need to access for those crops and to make use of it that we are talking about. And by way of recommendation and conclusion, we are saying that when nourished mothers are likely to survive child
It's like network has cut him out, but he was already concluding then. So we would like to appreciate him for that wonderful presentation, really bringing in the connection between nutrition and PPH and what we must do to see that we prevent PPH. So please, Dr. Joe, want to respond to the question by Dr. Uche. And before you comment, sir, I'd like to let us know that after this, we'll be taking a closing remarks and we'll be taking a group picture. And the group picture will be expected to put on our videos and give a bright smile. Okay, so please, Dr. Jumbo, please.
Okay, thank you. That's it. Dr. Uche, thank you for your questions. Okay. Now, it's a national program, the Federal Ministry of Health. They are looking at it critically, sending it down straight to the primary healthcare centers where there could be incentive for mothers who have had a normal delivery in a facility where there are skilled health attendants or in a hospital recognize the hospital. Now, the idea came up from a lot of studies, from feedback among all these traditional birth attendants. Why do you think that patients are still coming to them to have delivery, despite the challenges, despite the morbidities and mortalities that have been associated with it? And during that focus group discussion and the in-depth interview, it was discovered that a lot of them continue doing it with the premises that maybe because of their culture, because of the recommendations from their spouse. And one of the take-home way out of it among all the participants was the suggestion that if they can be given incentive, like a pregnant woman who left the traditional birth attendants or maybe church where they are doing free delivery or whatever, and now present herself to a health center, she should be recognized and acknowledged with an incentive. Nothing is too small. Even though the free maternity care is free, but they are not coming. But the few that are coming, acknowledge them with that incentive. It's not small. It can be 5,000 there. It can just be Pampers, just 2 or 3, cartons of Pampers for 2 weeks or 3 months. They will appreciate it. And they will go, it will go a long way to encouraging others to say, okay, she delivered and they gave Pampers. I will try to deliver there. And the essence is not to begin to give them money, to ensure that they deliver in the facility where they are skilled birth attendants. I think I've really answered you. Thank you.
Yes, thank you very much, sir. It's wonderful that during the course of this call, we've heard so much that the government is doing, some of the things we've never heard before. I would like to say that this was really a good session to really hear all these things, that the government is trying to do, to see that we reduce the indices, improve them, and they reduce maternal mortality rates and all that. So that's really welcoming. And I know that Mr. Odo said something about MMS. I'm just probably maybe you put it in the chat box. How readily available does Delta State have it? Our mothers that attend antenatal, do they have access to it? Are they going to give them? I think it's something he can put in the chat box. So at this point in time, I would like to especially appreciate all our presenters. I would like us to please appreciate our presenters on the chat box with whatever emoji you want to use, clap, whatever. Let's appreciate them on the chat box. Our presenters have done awesome. And also appreciate yourself being on this call. I want to, we're going to be taking our closing remarks now. And remember, after this, to be taking a group picture. I have the special honor to invite our MWAN president-elect. One of the presenters described her as his bosom friend, and I was jealous. I said, okay, let me go and look at my own bosom friend too. I want to especially welcome Dr. Oyowa to please take our closing remarks, please.
Good evening, everyone. Can you hear me?
Yes, we can hear you.
Yeah, standing on every existing protocol. Thank you, Dr. Chinyere Amaka Onobugo, Chairman MWAN National Maternal and Child Health Committee, for your inspiring and insightful remarks. To our esteemed presenters and participants, we express our heartfelt gratitude for your active engagement and contributions to this webinar. As we mark the 2024 Universal Health Coverage Day, we reaffirm our commitment to ensuring that every pregnant woman in Delta State has access to timely, affordable, and quality maternal health care services. Together, we can make a difference. Let us continue to advocate, educate, and support one another in our quest to reduce maternal and newborn deaths in our dear state. Once again, thank you all for being part of this important webinar. May our collective efforts yield positive and lasting impacts on the lives of women and children in Delta State. Stay safe and let's keep shining the light on quality maternal health care. Thank you very much. Over.
Thank you very much. And that was the voice of our wonderful President-elect, Dr. Owa. Thank you so much, Ma. I think it's time for us to take our group photograph. So please let's have your videos on. Please let's put on our videos. Okay. Hey, nice seeing everybody's faces. Yes. Dr. Olajide, why is your video not on? Okay. So I think we can take our let's know whether we've taken our pictures so that we can close. So let's say cheese. Dr. Ayi, have you snapped?
Are we snapping ourselves?
No, don't. Dr. Uche, see your face. No, what is snap
It
on?
has
Don't
come.
tell us.
People are prepared to sleep.
Okay.
This one you are
Dr.
looking
Ayi,
fine,
have you
like
put
Daniel,
good
please
pictures?
snap for us. Thank you.
I say cheese.
Daniel is snapping for us.
Hey, good to see everybody.
Thank
Thank you so
you.
much. Thank you,
Is Daniel
everyone.
there?
Okay, bye.
Bye.
Daniel, have you snapped?
Bye.
Yes, ma, I took a shot.
Thank you, everyone. We appreciate you all. As we commemorate
Thank you.
universal health coverage, we're hoping that we can improve the quality of maternal health care services. Thank you so
Yeah.
much. Thank you. Thank you. Bye,
Thank you.
everyone.
Good night. Bye.
Bye.